It's my pleasure to introduce our next speaker, Dr. Carol Persad, who is a clinical associate professor in the Department of Psychiatry. She got her PhD from Michigan State University and then realized the error of her ways and did her postdoctoral residency at the University of Michigan. She's the director of the neuropsychology program in the Department of Psychiatry and the neuropsychologist for the STIM program, which is our deep brain stimulation program. She's also the director of the University Center for Language and Literacy, and her research interests focus on the cognitive profiles in dementia and movement disorders, and she'll be talking about Lewy body dementia and Lewy body disorders. Let's welcome Dr. Persad.
Thank you. I hope everyone enjoyed lunch. Had a good time? Good. Okay, so we're going to talk a little bit about Lewy body dementia and dementia in Parkinson's disease. But before that, we have to back up a little bit. These are what's called Lewy body disorders. And really, it's a group of disorders that really have at their core feature the similar brain pathology. And we're talking about something called Lewy body inclusions. And what are those? These are abnormal deposits or clumping of proteins, a protein called alpha-synuclein, that form these clumps or these inclusions in cell bodies. And when we're talking about the brain, we call them neurons. And because of this, these inclusions, it causes the neurons to work less effectively and eventually die. Okay? And this is a picture of what a Lewy body inclusion looks like. It's actually quite well encapsulated. It's nice and round, and it gets in there, and it starts to cause all sorts of problems. And Parkinson's disease is a Lewy body disorder. That's what the underlying pathology that happens in this disease. But so is dementia of the Lewy body type and Parkinson's disease with dementia. These were first discovered in 1912 by, guess what, Frederick Lewy. Therefore, we've got the name. But it wasn't until about 1976 did we think about this further than Parkinson's disease, and we developed a term called dementia of the Lewy body type, which is what some people might have heard already about in this room here. So let's talk about Parkinson's disease first. The Lewy bodies are most often found in the brainstem and substantia nigra in different areas in Parkinson's disease, and they affect neurons that are important for dopamine. And I'm just going to show you a really quick picture here. Unfortunately, I don't have, let's see, does it work here? Can you see my little cursor moving? Okay. So this is the substantia nigra in this area, and right here in a normal person, this is what it looks like. In a healthy person in Parkinson's disease, some of you guys have probably seen this before many times. This is where the cell neurons are dying. And here is a cell in the substantia nigra, and there's this wonderful little Lewy body getting in the way. Okay? Now, in Parkinson's disease, aside from obviously all of the motor symptoms and the other symptoms that everyone experiences, many people also experience mild cognitive problems. Cognition is a term that we use for thinking that includes things like memory, attention, language, problem solving, all those kinds of things. And more recently, some of you might have heard a new term that we're talking about in terms of Parkinson's disease of mild cognitive impairment. Okay? So what is that? Mild cognitive impairment is a term that's been around actually for a while when you're talking about the Alzheimer's dementia literature. Basically, what happens is compared to someone else just like you, your age, your education, someone with mild cognitive impairment is going to have some problems in a specific area of thinking, okay? Usually, the original term for this is that the main problem was a memory issue. Now, we all have some memory issues as we get older. We have a little more trouble finding names. You're not quite as effective as you used to be. That's normal. But there are some people out there who have a lot more problems with memory, and we would give them the term mild cognitive impairment, okay? But you can also have some deficits in other areas of attention, language, and what we call executive functioning. That's another term you might have heard with Parkinson's disease. Executive functions is this umbrella term that refers to things like decision-making, problem-solving, organization, things that make us a logical human being, okay? That's what we talk about as executive functions. When you talk about MCI, you often talk about what's called single domain. There is problems in one area, or multi-domain. There's problems in many other areas. But what's important about this is that there is no functional impairment. The person might still have problems with memory or something else, but they're still able to get on in daily life and not have a problem. Often is still working, taking care of the house, doing what they normally do, okay? Now, why is it even important to talk about this? As I said, this is originally developed in Alzheimer's disease literature. And the idea is we're trying to look for ways of identifying really early signs of Alzheimer's. That's extremely important when you're talking about treatment. If we want to find something effective, the earlier we can treat something, the better outcome it's going to be. And as I said before, in Alzheimer's, the main characteristic there is that it's a significant memory problem. And we have shown that MCI is a big risk factor for later development of Alzheimer's disease. And in fact, for those who have this MCI with memory problems, as many as half of them, 50%, will go on to develop Alzheimer's disease in a couple of years. However, that also means there's another 50% that doesn't, that might either stay stable and not change or actually get better over time. Okay. But as we keep looking at the research, we realize that there are actually different types of MCI, and not everybody has memory problems. You can have people who are just fine with memory, but might have a lot of problems with language, or might have a lot of problems with those executive functioning deficits, and realizing that maybe it's not as clear-cut as we think. Now, MCI as a concept in Parkinson's disease is much newer. Understand that this is not a separate disorder. When we're talking about Parkinson's disease, we're using it just to characterize the fact that there might be cognitive problems, okay? So it's not that you have something additional. In people, we've talked about the cognitive problems that we can have in Parkinson's for a long time, but it has now been termed as Parkinson's disease MCI, okay? There's a lot of controversy whether or not we should even bother using this term because of the confusion. However, I think one thing that it has done, it's actually been very useful because it has helped highlight the fact that a lot of people do have some problems with thinking. Something that, until more recently, isn't really discussed in the doctor's office. And I know I can see people nodding their head, and every time I ask, if I ask right now, when you were first diagnosed, how many of your doctors ever asked, did you have problems with memory or thinking? Did anybody at first? A couple. It's not something that traditionally had been asked. I mean, of course, we do here at the University of Michigan all the time. Dr. Chi knows exactly. But typically, it's not recognized. And yet, you know, if you have Parkinson's disease or the family members, realize sometimes that something's wrong, but it's never something discussed. It's always, do you have tremor? How's the movement going? So MCI in that sense has been pretty helpful to really highlight that there can be these changes and we need to address them. When we talk about MCI and Parkinson's disease, we're talking about something that looks different than Alzheimer's. And typically, we're going to see these weaknesses in those executive functioning deficits that we're talking about, including working memory, the ability to keep something in mind and do something with it. Complex attention, and I know many of you know this. In fact, all of us have a little trouble as we get older, but doing two things at the same time can be very difficult. Coming up with words quickly. Not that you can't do that, but to do it very quickly and to search for these things. And problem solving can be difficult. Learning new things can be a problem. Just like your movement slow down, so can your thinking. It's very much parallel. So sometimes it's not that you can't do it, it just takes you longer to process it, which can be a problem when the rest of the world is moving just as fast as it used to be, and it's harder to keep up sometimes. We often don't see memory problems in Parkinson's, but if we do, they're a little different than what we see in Alzheimer's disease. You can have learning difficulties and some problems finding what it is that you want to remember, but it's usually more due to the problems in those executive functioning. How do you organize and find the information? Your brain stores it in a certain way, but then you got to figure out how to find it. If you use the analogy of a cabinet and every drawer has something different, and you've gone in and decided that everything to do with your what happened yesterday goes in the first cabinet, and everything that is something about your family that you did, it goes in the next cabinet. When you're asked a question about it, you got to go figure out what cabinet to go to. That's different than a memory problem. Whereas if I say to you, oh, do you remember? It's when we did this. And you go, oh, I got it. I've suddenly given you a way to find it, and all the information comes back. That shows me that that is not a memory problem. It's stored there. It's a different system. It's how you find it is where the weakness is. Okay. And as a result, that if I give you something to remember, for example, if I just give you a random list of words to remember, and you have to figure out how to put it all together to make sense, so not only can you learn it, but remember it later, that's a lot harder than if I give it to you and present it to you in a way that's organized, that's familiar, that makes it easier to do that. Now, this is something, honestly, that we all can benefit from, but it's a little bit harder in Parkinson's disease, so the more I give you that external structure, the easier it is going to be to remember it at a later date. It's been suggested that as much as a third of people at initial diagnosis of Parkinson's disease have this MCI or have these problems, which will increase as the disease progresses. Now, the risk of progression if you have MCI to dementia isn't well known. We do know, and the numbers, honestly, when you look at it, will range anywhere from 20 to 80%. It really depends on how the research is done, how long they are following people, but there's still a lot of work to do. But we do know that if you have significant memory problems early on, you are at greater risk of developing dementia, Parkinson's disease dementia. Not all MCI is the same. So what we are finding is that those executive functioning deficits that are very common in Parkinson's, they stay stable pretty much throughout most of the disease course, and they're not a good predictor of changes later on. But as I said, the memory, semantic fluency is the ability to find words within a certain category that are related. Visual spatial, being able to perceive things and understand what you're seeing. Those things, any changes there, that's more of a better predictor of developing dementia later on. So what is dementia? This is a term that's very confusing. And in fact, I was just at an Alzheimer's symposium last week, and the same thing came up. People are asking, what is dementia? What is Alzheimer's? Dementia is the general term that's used. It refers to impairments in multiple areas, multiple cognitive domains, okay? So you're going to have problems with memory and attention and executive functioning. So more than one thing. It is going to interfere with your ability to function on a daily life, okay? People are going to have trouble driving, doing the housework, taking care of the finances, and sometimes even self-care. Trying to remember to take that shower, or what is the sequence you need to do to brush your teeth. It can be very impairing. And it's a progressive decline. It's going to continue, it's going to be gradual, but it will continue. That is the definition of dementia. There are different types of dementia. So Alzheimer's is one type. Now, people use those two terms synonymously all the time, but Alzheimer's is a type of dementia. As is, which we'll talk about, dementia of the Lewy body type, the Parkinson's disease dementia, and there's others too. Frontal temporal dementia, which is a different type, where the initial presentation is more problems with problem-solving, decision-making, but also a lot of unusual behavior, being very impulsive, being inappropriate, a lot of behavior changes, and vascular dementia related to mini strokes and other things. But no matter what, dementia affects your quality of life, your interactions with others. There's a lot of burden on family. And it's really important to understand what this is and to diagnose it as early as possible. Because when you do that, you need to make decisions. If there really is the beginning of a dementia, we have to be thinking long term, thinking about driving. When should somebody stop driving? Who's going to start making the decisions in terms of finances or medical decisions? Should you be thinking about a power of attorney? In some cases, people are still working. When do you stop working? Or when do you need to have assistance with living? Maybe you can't live anymore alone. The more you understand what's happening, the easier it is to come up with plans for the future in this. Supervision of medications and other tasks for safety. If someone has a memory problem and you're taking medication, you need to make sure, one, either that they remember to take the medication, or two, that they're not taking it 3 times because they forgot they took it. So there has to be some supervision. The earlier, though, we can get a diagnosis of this, the better, because that means the person who has it can early on participate in conversations about what they want for the future, what their wishes are. We don't want to do this much farther down the road when you don't have a say anymore. If you're concerned about dementia, you really need to get a neuropsychological evaluation where you're going to look at what the problems are, what this looks like, but also neurological evaluation. You want to rule out any other causes for these changes. Sometimes things can happen that affect your thinking because of medications, either side effects or interactions. Depression, anxiety, other psychiatric disorders can affect your thinking, as can other diseases. You want to make sure, for example, uncontrolled diabetes can have problems, can have effects on your cognition. So you need to make sure that if you start seeing changes, go and have them addressed, and let's see if there's anything else there that we could be doing to help you. So when we're talking about Parkinson's disease, there's these 2 terms that keep go back and forth. One is the Parkinson's disease with dementia, and the other one is dementia of the Lewy body type. Parkinson's disease with dementia is when motor symptoms have occurred first, often for many, many years, and then cognitive changes will follow. Dementia of the Lewy body type is when the cognitive and any behavior changes happen first, followed by the Parkinsonism. And we talk about at least 1 year. But there's a lot of overlap between the symptoms that you'll see. And this 1-year distinction is actually pretty arbitrary. There's still a lot of controversy right now whether or not these are really 2 separate disorders, or whether it's really all the same thing and it's just an issue of the presentation. And how because you even know yourself in terms of Parkinson's disease, you could turn around to someone else right beside you in this room and realize you don't have the same symptoms. How it came on, it's not, doesn't look the same. So the question is whether or not these are really the 2 of the same disorder. And we don't know that yet. But traditionally, if we think about this, Parkinson's disease dementia has more severe executive function deficits. We do start to get memory problems. Things like object naming, being able to name something, is actually relatively intact, but you get more of this slow processing speed and a lot of visual problems. What are the risk factors for dementia and Parkinson's? Well, the type of symptoms that you have. People who are tremor predominant actually have less risk of dementia than if you start off with rigidity and gait problems. Age of onset is a big risk factor. The older you are, the more likely you are to develop dementia. More severe motor symptoms. We're going to talk about visual hallucinations all the way through, but there's some controversy over that because sometimes it's medication related and not necessarily a good risk factor of dementia, but it can be. And of course, as we said, multi-domain MCI, the more cognitive problems you have in the beginning, the higher your risk is for developing this later. And as I said, the data is still unclear as to risk factors, and it's amazing when I read them, and the numbers are all over the place. But at least some of the longitudinal studies, the studies that follow people over time, suggest that potentially as many as half of people with Parkinson's will develop dementia within 10 years from diagnosis. So if we talk about the dementia of the Lewy body type, or what we call DLB, this is the definition that we need. Dementia must be present. And there are three core features, three things you need to think about. One is visual hallucinations. The second is fluctuating cognition. And the third is Parkinsonism. And then there are all these other suggestive features that can go along with this. I'm not going to go through them all because there's a lot, but when you look at them, you kind of realize, wait a minute, these are a lot of things that also can happen in Parkinson's disease. So there's a number of them related to sleep disorders, like REM, sleep behavior disorder, restless leg syndrome. And when you talk about dementia, the Lewy body type, we'll talk about two categories or two classifications, either probable or possible dementia. If it's probable, there has to be at least two of those, the three main symptoms that we just went over, or at least one that's definite there and one or more of these suggestive symptoms, whereas possible, it's just one or the other. What's really interesting about this is that dementia of the Lewy body type is actually the second most common type of dementia behind Alzheimer's. And yet, most people have never heard about it. A lot of that has to do with that it looks initially like Alzheimer's a lot of the times because those cognitive problems happen first before the Parkinson's does. And until we even had an idea of what that there was such a thing, that, as I said, identified in the late 70s and really didn't take off until the 80s, many people were misdiagnosed. A slight preponderance in males than females, and very similar age of onset into Alzheimer's, which again, makes it more difficult to sort of separate the two. But they have typically someone who has dementia Lewy body disease has a faster rate of progression than Alzheimer's. The motor symptoms are very similar to Parkinson's disease with dementia and Parkinson's disease in general, although there's some suggestion that it's a little more symmetric at both sides initially, as opposed to often Parkinson's disease is one side of the body. So if we think about what this looks like, there's this thing called fluctuating cognition. And this can vary either very quickly or across the time. But if you think about sort of even your motor symptoms, this on-off phenomena that many people experience, is kind of like that with the cognition. Sometimes you're pretty on, and then other times you're really confused, and sort of this up and down that can happen. So this fluctuation is considered a key feature when we're talking about Lewy body dementia. Another thing that's also very key is what we call visual spatial deficits. So if I'm testing somebody, they have a hard time matching two pictures and being able to say they look the same, or copying a drawing. And it's not because of the motor problems, it's because they're not really understanding what they're seeing anymore. So people, and this might be partly related to the visual hallucinations that we talk about. But they might also have trouble finding their way around, getting lost, even in a familiar environment, not fully recognizing that what they're picking up is the object. Or often I'll hear a lot about they're looking for their glasses, and the glasses are sitting right there because they're not able to really understand and perceive it's right there. But what's interesting is that diffuse Lewy body can also see a lot of memory and other impairments that are very similar to Alzheimer's, and we'll come back to that in a minute. So as you can see, there's a lot of overlap between Parkinson's disease dementia and Lewy body dementia. it's suggested that Lewy body dementia has more severe deficits. And as I said, more likely related to memory. You can see hallucinations in both, but it's possible that people have argued that what's different about this is that in dementia with Lewy body type is that the hallucinations can occur spontaneously even before we start any kind of medications. Whereas in Parkinson's disease with dementia, it's more often due to chronic dopaminergic therapy. What's also more common in dementia Lewy body disease are delusions or unusual thinking. So often there's sort of a paranoid type approach, thinking somebody's out to get them. And that can happen early on in the disease. I didn't list them all. There's so many autonomic features, but that are common to both, that you can see in both, and it's not a good sign at all in terms of separating these two disorders. And as you know, it can also be difficult to figure out whether this is really related to dementia or whether it's related to all the medications you're taking, because there's definitely a lot of side effects there. The REM sleep behavior disorder can be seen in both Parkinson's disease and dementia Lewy body. It's been shown to potentially occur as 5 years or more even before the onset of any motor symptoms or cognitive symptoms. And what's interesting is if you take people with REM sleep behavior disorder and you look at them, and those who go on, many of them will go on to develop this, they actually show very similar patterns of cognitive impairment, these MCI that we're talking about, years before, even before the motor symptoms. So, what exactly that link is, we don't really know, because not everybody with REM sleep behavior disorder will go on to develop this. But there's definitely some relationship here. So can we differentiate this in terms of pathology? Well, not necessarily, because both disorders have these Lewy bodies in the same general areas. Now, in dementia Lewy body type, there are more of these, typically in the cortex, the higher areas of the brain. What's interesting about diffuse Lewy body as well is that they have more pathology that looks like Alzheimer's disease. What we call these plaques and tangles that we talk about a lot in Alzheimer's. You see those more in what many people talk about as dementia Lewy body type, which would account for the fact of this more rapid progression that we were talking about, the decline and the memory problems and other things. Again, talking to why it gets really confusing clinically to sort of tease these two apart. And in fact, as many as 80% of people with diffuse Lewy body have said have had this AD pathology. And we talk about this as a mixed dementia. So whether or not they were the unlucky people who got both at the same time, or whether there's something about the underlying process, we really don't know. And you see that at much smaller numbers in Parkinson's disease. And as I said, a lot of this pathology, these changes in the brain, are probably what's underlying the memory and other symptoms that look a lot like Alzheimer's disease. But there currently aren't any biomarkers that we have that can distinguish these two. There's a lot of research looking at this, but nothing has really panned out yet. Because when you look on MRI, you see some similar degrees of what we call cerebral atrophy or shrinkage of the brain in these two disorders. And they show them in the same areas, although there's some suggestion that in diffuse dementia Lewy body type, that there might be greater shrinkage in areas that are what we call the temporal parietal occipital lobes. And a lot of that's very similar in Alzheimer's as well. But regardless, if someone has, so up until now, we've talked about these two dementias. It's still unclear whether or not there are two separate ones. But if you do have it, what are we going to do? Okay? The first thing is talking about medications. These are two medications that are out there, and there are others. But research has shown that these two, at least, can be effective for treating cognitive problems in either one of these disorders. But you have to understand, though, that it is mild. We're not going to have significant improvements. But it might help stabilize things so that it doesn't get worse for a while, okay? One thing, though, if someone does have dementia Lewy body type is we want to be very careful about using any antipsychotic medications because it make the symptoms a lot worse, okay? So it is important to sort of at least have an understanding what the presentation looks like before we think about treatment. Just as right now, what other treatment? Just because someone has dementia doesn't mean we stop treatment. We still want to talk about physical therapy because there's an increase in risk and falls as you have dementia. We definitely still need speech therapy if that's an issue. Exercising is really, really key. You think about exercise, it not only helps the heart and the lungs and everything else, it does help the brain. This is an older slide because we're talking about at least 30 minutes 3 times a day. And we don't have to, we're not talking about major aerobic exercise and things.
3 times a week.
Pardon?
3 times a week.
Oh, what did I say? Nope, 3 times a day. Sorry, 3 times a week. That's a lot. The newer numbers are actually 5 times a week. And it's very funny because the government has come out, because it was supposed to be 5 times 30 minutes, it is now 7 days at 22 minutes to somehow even it out. Okay. I'm not sure why we had to say it that way. I guess they figure it's easy to remember every day 22 minutes as opposed to 30 minutes 5 days a week, but that's okay. But it's really interesting because we have shown that with exercise, and it can be just walking for 30 minutes a day, okay, that we can improve cognition. Whether or not we're talking about healthy people, MCI, or even early Alzheimer's, we can see an improvement in memory and attention. Again, we're not talking about a reversal, we're not talking about huge gains, but we can document that there are improvements in your cognition. Exercise can also improve depression and other things, which is extremely important because depression and anxiety, what does it do? It affects your memory, it affects your ability to pay attention, it affects your ability to sort of make decisions and solve problems. This exercise is great because it can be used to treat a number of different things. The other thing that I don't have down here, the other thing about exercise often is that for many people, if you go out to a group or you go walking with somebody, it increases the amount of social interaction you have. And social interaction, believe it or not, has been shown to be one of the best protective factors of developing cognitive problems. Not quite sure why, but the more friends you have, the more social you are, you get out there, it turns out to be a protective factor. And exercise can often be that. We need to treat the sleep disturbances. Once again, if you have poor sleep, and I'm quite sure everybody in this room has experienced a time when you just didn't sleep very well, and the next day you could not pay attention. It was a lot harder to remember things, to learn something new. It is what it is. So people with obstructive sleep apnea, for example, show these deficits and actually have a lot of executive functioning problems. So the more we can treat any sleep disturbances, the better. So we want to look at all these other factors that might be affecting how you think. So of course, one of the questions always is, what about cognitive training? I mean, there's so many computer programs out there. Cognitive stimulation, you want to keep your mind going, is definitely important. I mean, even this, that old adage, if you don't use it, you lose it. That does apply to your brain. But you have to understand, though, that there are all these cognitive programs that are out there. They're great, but I would not go and spend lots and lots of money on them. Most of the programs that are out there do not have any research backing, and even though you might get a lot better at that program, there's nothing to suggest that it then transfers to real life, okay? but anything that you can do to keep yourself stimulated. If you want to do crosswords, you want to do Sudoku puzzles, you want to learn a new language, take a course, do something. That is really important. Some people love these computer games. I think they can be good, but don't put high hopes on them and don't spend lots of money, okay? Obviously, I don't have any interest in any of these computer games. But, you know, like I said, if it's helping you and you enjoy it, go ahead. But you don't have to rush out there and go and buy these really expensive programs. And as for person who's working with someone who has dementia, then there's things you need to think about. You want to present tasks one at a time. Don't get don't get the person overwhelmed. Let them be able to really mobilize and use their cognitive skills that they have on this one task. Speak a little more slowly, because if they are having a little problem processing things quickly, give them some time. Repeat information to help with learning. Don't expect that they're going to remember the first time. Write it down. Anything that's important, write it down. If you have to put notes up, you got to put notes up. My father-in-law, unfortunately, has Alzheimer's, and he's probably in the moderate stage now. My mother-in-law has got all these notes around, especially on things that he keeps asking over and over again, like what his age is. Yes, his mother has passed away, but other things in terms of remember to put the seat down on the toilet, or, but if that's what you have to do, that's okay, because it's an external cue, and it also helps take it away from you that you're not there nagging all the time. Using structured activities that are routine with schedules are good. And you hear about this a lot. People who have dementia often can function at home for a long period of time. And once you take them out and go to a nursing home, that they seem to decline very rapidly. It's just because, not that they got worse, it's just because at home they're very familiar with what they're doing. And it's such overlearned that they just can keep doing it and doing it. So they can function a lot better with that. And of course, just reduce distractions. Okay. All right, well, I kept it short because we're over time, but thank you. So if anyone has any questions? So the question was, if you're diagnosed with MCI, how often you should be retested. Typically, if you have that diagnosis, we usually suggest about a year and a half to 2 years, unless things change a lot faster. So the question is, I mean, there's still some confusion, of course, about Lewy body dementia and Parkinson's dementia. Why do we even have these two different names? Because the thought has always been that in Parkinson's disease dementia, that the pathology was always in the lower part of the brain. And the diffuse Lewy, or dementia with Lewy bodies, there's lots of different names too, by the way. I keep going back and forth, and I'm sorry. That again leads to this confusion. Is because it presents first with the cognitive problems, and it has these hallucinations and these fluctuations initially. That initially people saw these as two very different things. And it's only been in further research that we're starting to understand there's a lot more overlap than we realized. So there's some people would get up here and argue that these are definitely two very different disorders, and other people would say, no, it's all along the same spectrum. So it's unfortunate, but we don't really know. But it's important to know the terms if it ever comes up, and in the doctor's office or just reading about it. At least you understand what people are referring to.
What do people die of? It's probably actually similar things that Parkinson's disease patients die of. So it's usually the complications, difficulty with swallowing causing aspiration and pneumonia, falls leading to hip fractures, and immobilization, not being able to move. Those types of things are actually what leads to death in these types of disorders. So not the dementia itself, or not the Parkinson symptoms themselves, but indirectly leading to it.
The same thing as other Parkinson's patients.
Yes. Yes. So just what you were saying, I'm sorry. I was saying yes, but it's the same thing as other Parkinson's patients, people with Parkinson's symptoms, it's similar causes.
Right. So the question is, the antipsychotic medication, is it long-term or short-term in terms of the side effects? If you remove the medication, it should improve. All right. Thank you.